Okay, we're going to try a little bit, something a little bit different right now to make it easier, and you'll still be able to review these recorded lecture. Nevertheless, this week we're going to focus on the posterior pituitary. We'll do the anterior next week. So let's talk about this. The functions of the posterior pituitary include the release of oxytocin and vasopressin. Now, posterior pituitary is really an extension of the hypothalamus. It's composed mostly of neural tissue. Okay, the hypothalamic nuclei will synthesize the neuropeptides vasopressin and oxytocin. They will package them in neurosecretory vesicles, but the vesicles leave the area of the hypothalamus, travel down on the hypothalamic nuclei axons. These axons are unmyelinated. What is going to lead to the exocytosis of these secretory granules of the neuropeptides are action potentials. So the action potentials traveling down the nuclei axons are going to help stimulate the release of the neuropeptides at the axon terminals. You do need to note this, that the axons also have some collaterals. Those are branches of the axons, some of which will terminate in the median eminence. Now, obviously, many of you probably reviewed what action potentials are, but just to help refresh your memory, action potentials, they will arrive at the axon terminals. And as they do, they're going to trigger calcium voltage gated channels to allow the calcium ion influx into these terminals. The calcium ions influx is going to lead to the secretory vesicles to fuse with the terminal membrane and thereby causing exocytosis, the release of the neuropeptides. As you can see here in this diagram, here we have the anterior pituitary here. This is more glandular in tissue type. This is more neural. Over here is neural tissue as well. And you do have some secretion to the brain sites from the parvocellular neurons, okay? Notice this is the superoptic nuclei. This is the optic chiasm. This is the paraventricular nuclei. These are dendritic secretions from the magnocellular neurons, okay? These are magnocellular neurons as well, okay? So they're in both areas. They have long axons, travel down through the infundibulum, and they terminate in the posterior pituitary. When you have axonic secretion of these neuropeptides, it is going to enter into the peripheral circulation right here. You can see this also in this diagram. Sometimes different diagrams give you a little bit more detail. In this case, same situation where you have the axons. Remember, they're unmyelinated, so they're not going to be super fast, but they're going to be relatively quick because it's also a very short pathway here. We have the infundibulum here. We have a portal artery here, and then you're going to have this capillary network here. And so what's going to happen is the release of these neuropeptides, oxytocin, vasopressin, and then they will be traveling along and eventually enter into the portal vein. Now, let's talk about oxytocin, vasopressin. Vasopressin also goes by several other designations. AVP, which stands for arginine vasopressin. ADH, which stands for antidiuretic hormone. Okay? I want you to be aware of that because sometimes, depending on what textbook, etc., they flip around and use these. But let's talk about these. Both of these are neuropeptides. They enter the systemic circulation via the venous drainage of the posterior pituitary, leading to the intercavernous sinus and the internal jugular veins. So very quickly, it's going to go into the general circulation. Both of these neuropeptides are composed of 9 amino acids, and they have somewhat of a ring structure, which I'll show you in the subsequent diagram. The interesting thing is that these can circulate in the systemic circulation unbound. In other words, we don't need a carrier protein or anything else. But as a result, you're going to have a relatively short half-life. See, the clearance of both peptides can occur in the kidney, and that's very rapid, which only makes sense because the kidney is going to be able to filter these out. There is also a lesser extent of clearance done by the liver and the brain. As I said, the half-life ranges between 1 to 5 minutes. Now, there's another peptide you need to be aware of. They're called neurophycins. These are byproducts of oxytocin and vasopressin. What happens is these products occur from post-translational pro-hormone processing in the secretory vesicles. So as the secretory vesicles have been discharged and are traveling down the axon and go into the terminal area, you're going to have some clipping of the larger pro-hormone parts. Those parts are going to be neurophycins, okay? The interesting thing is, what do these neurophycins do? Well, they believe to play a role in vasopressin transport from the magnocellular neurons to the final release of the posterior pituitary. It's been found that mutations of the neurophycins can lead to AVP deficiency, and this is due to improper targeting of AVP into the secretory granules. What that basically means is that somehow there may be some mutations that exist of the neurophycins. And so what happens is that you're going to have this arginine vasopressin, ADH, antidiuretic hormone, however you want to label it, it's going to end up deficient. And this is due in part to the improper targeting of AVP into specific secretory granules. We'll discuss more about AVP deficiency disorders later on. It's interesting to note that these mutations can result in a form of an inherited disease referred to as familial neurogenic diabetes insipidus. In other words, it's a type of diabetes insipidus, but it's occurring in those neurons that are making the vasopressin, and it is hereditary based. And that's where we get the familial part. Here are the comparison of the two. If you notice here, you have this ring structure that occurs. What you have is a disulfide bond between the two cysteines here and here. But when you start comparing the amino acids, you know, so well, okay, tyrosine's here and ASPN's here. Notice that the big difference in oxytocin and vasopressin is this AVP has phenylalanine, this one has isoleucine, and then there is a slight difference in the arginine and in the leucine for the oxytocin. Presumably ARG is what differentiates in a major sense for the arginine vasopressin, AVP, all right? You don't have to worry, I'm not going to ask you exact, what amino acids make up to oxytocin or vasopressin. That'd be something you could really pick up and just, reference me. But it is important to know its structure, how they are basically made up of really both 9 amino acids, and there's really only 2 amino acids in the entire structures that differentiate AVP from oxytocin. Okay? Now, let's talk about oxytocin a little bit more. We're going to focus in on oxytocin, then we're going to get into AVP. Oxytocin is synthesized by the magnocellular neurons in the supraoptic and the paraventricular nuclei of the hypothalamus. They have really two major or main physiological effects. The uterine contractions during childbirth. And we've mentioned that before. We're going to continue and go into it a little bit more detail this time, as well as the stimulation of what is called the milk letdown reflex. And I'll get more into that in a few minutes. Now, there are several other interesting possible effects, but you have to keep in mind something. Human beings are not lab rats. You can't just throw them into a lab and just say, okay, why don't you do this, 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 or take apart your brain. And you can't do that kind of stuff with human beings. But they can make very detailed clinical trials that give them an indication of what some of these other effects are. For example, with oxytocin, it may be involved with the release that may play a role in males in ejaculation. Also, it may play a serious role in maternal bonding and sexual behavior. There is some evidence that it is involved in the reduction in anxiety. And actually, they've been finding some studies with exogenous, meaning outside pharmaceutical application, that appears to have some benefits for autism and autism spectrum disorders. If you're not familiar with that second term, it used to be called Asperger's syndrome. Now they've reverted back to calling it just autism spectrum. You're somewhere on that spectrum of autism or symptoms. It also may play a role in cognitive social memory, including olfactory memory. Now, if you're not familiar with that, think about this. Have you ever gone outside and you take a sniff outside and you go, smells like spring, smells like fall. I can smell the soil. Or I go to the beach and it connects me, the smells of the beach connect me to when I was a little kid going out to the beach, something to that effect. Now, here's a diagram that shows some of all the different effects. Now, I can tell you a couple of major physiological effects. Some of these start to move toward what we would be considering more psychological. I mean, autoregulation of the autoexcitation during birth and suckling, no problem. Neuroendocrine, well, this is where we get the beginning of the attenuation of the HPA. Remember, that's the hypothalamic pituitary axis. And this is in the response to stress. So that's neuroendocrine. Now we get into cognitive. That's social memory, olfactory memory, social, maternal behavior, pair bonding, sexual behavior. That's why oxytocin has played a major, has been given how can I say it, like the title of the cuddle hormone, okay? And then also anxiolysis, anxiety, it seems to reduce. It seems to have a positive mood effect on human beings. Anxiorexiant effect, same thing. I would not be surprised that they have done some studies trying to use that as perhaps something for people who have panic attacks and anxiety with certain mental disorders. Now, of course, we can go even further into this, into all sorts of really serious detail. But this is giving you an insight into the endocrine effects of this 9-amino acid peptide that seems to play some serious roles in not only birth and lactation, but in a variety of other structural buildups that occur in the brain that lead to unique behaviors that we see with childhood, adolescence, adulthood. Even in fetal development, there's some evidence that oxytocin is involved with the organization of the social brain. Okay. Now, I want you to be aware of also something else. At birth, of course, obviously, you have the uterus that has been stretched out because of the presence of the fetus, which is now the neonate. So when you have the childbirth actually occurring, oxytocin then plays a role in uterine contraction so that the uterus will basically contract back to its normal, roughly normal size and shape. Also, we're talking about autoregulation, so the auto-excitation of birth, suckling, and lactation, the milk letdown reflex. The rest of it, as you can see, childhood, adolescence, adulthood, we're looking at proper parenting, pair bonding, we're looking at social behavior, social recognition, cognition. You're looking with adulthood to how we deal with perhaps the appropriate responses to intruders or competition and aggression, sexual behavior, bonding, feeling trust, emotion, love, and also neuroendocrine effects such as attenuating the HPA axis when it comes to stress. Now, when we talk about oxytocin and the uterine contractions during childbirth, let's take a look at that for a few more minutes. Oxytocin receptor levels are going to increase. This is an upregulation situation that occurs in the uterine myometrium. If you're not familiar, again, just to remember that that's sort of the muscle, the smooth muscle layer that exists between the inner and outer layers of the uterus. So why are we having an upregulation? Well, that's going to increase the oxytocin sensitivity. So the density of the receptors, this is mediated by estrogen levels. So as the estrogen levels rise and continue to keep rising up closer to pregnancy, you have a greater amount of sensitivity to oxytocin for the uterine muscle layer. And this sometimes is also causing things like Braxton Hicks and the actual onset of childbirth. Now, what you notice is enhanced responsiveness by the uterine myometrium, and this is due to enhanced gap junctions of the smooth muscles and increased production of prostaglandin. So in other words, as we've been getting more responsive to oxytocin, the cell-to-cell communication in smooth muscles in the myometrium are going to be coordinated and thereby enhanced by having this connection, the gap junctions between the cells. Also, you're increasing the production of prostaglandins. Now, of course, this is all part of a positive feedback mechanism, and the way that it ends is by childbirth. As I mentioned earlier, oxytocin plays a role in decreasing postpartum bleeding and the uterine volition. In other words, basically, sometimes they'll say uterine involution. Basically, it's returning the uterus to its normal size. Okay, so it's going to shrink down back to its more normal size inside of the pelvis. Now, there are, as I mentioned to you, other possible secondary roles for oxytocin postpartum. And these are kind of interesting because they kind of start moving us toward that nurturing behavior, but also dealing with stress and other factors that play a role. What has been found is evidence for potentiation of ACTH release by CRH. So instead of it giving X amount, when CRH is present, it is going to stimulate even more ACTH release, which of course then would play a role on the adrenals and thereby perhaps enhancing cortisol to deal with stress and maintain glucose levels, et cetera, et cetera, et cetera. That is what cortisol does. It plays a role in helping us to deal with stress. What isn't stressful when one faces childbirth, when one has it afterwards? It's been a tremendous drawing down of resources physiologically in the woman. Also, there will be an interaction of the AVP receptors to produce vasoconstriction. Now, this is where we get into some of the concepts of decreasing postpartum bleeding. Because what you're really doing is you're beginning to constrict a lot of the blood vessels to thereby, yes, that could also increase blood pressure, but what you're also doing is constricting them to reduce blood loss after the birth. Also, this presence of oxytocin is going to cause stimulation of prolactin release, which we'll get into more next week. But just to give you a tip, prolactin is involved with the production of milk in the breasts. Finally, oxytocin has been found to influence maternal behavior and, interesting enough, on amnesia. So if we look at this, this is a positive feedback, the induction of labor, estrogen from the ovaries. It's going to increase oxytocin receptors on the uterus. And so what you have is this oxytocin from both fetus and the mother's posterior pituitary. They're going to stimulate the uterus to contract. They're going to stimulate the placenta to make prostaglandins. The prostaglandins are going to feed back in both a short and in a long loop. The short loop is it's going to basically enhance, stimulate the placenta to make even more prostaglandins. So in other words, contractions equals more release of prostaglandins, but at the same time, some of these prostaglandins are going to feed back and enhance the oxytocin release, which will again stimulate the uterus to contract and stimulate the placenta to make more prostaglandins. Now, what about oxytocin and the stimulation of the milk letdown reflex? What is going to happen is oxytocin is going to stimulate milk ejection by producing contraction of the myoepithelial cells that line the alveoli and ducts of the mammary gland. This is milk ejection. So think about this. Prolactin has already started the milk production in some of the cells in the mammary gland. But in the basic alveoli area and in the ductwork, we've got to have something that is going to contract a little bit, and that's the myoepithelial cells that are going to help push the milk up to the nipple and really out of the nipple. Okay? Now that we've gone through all of that, we've got to talk a few minutes about receptors. Oxytocin's receptors are a little bit simpler than definitely the vasopressin ones. Oxytocin's effects are achieved by binding to the cell membrane G protein. This one is GAQ/11. This is of course, protein-coupled receptor, G protein-coupled receptor. Now, these receptors are expressed in the uterus, mammary glands, and in the brain, which accounts for perhaps some of the social conditioning and some of the maternal behavior that is elicited from, of course, the brain. What happens when we have this binding to this particular G protein? Well, you're going to get binding of this is going to lead to the activation of phospholipase C. If you remember phospholipase C, which we chatted about in the first week, that's going to produce an increase in inositol triphosphate, IP3, and 1,2-diacetylglycerol, which otherwise goes by the acronym DAG, D-A-G. This is going to lead to an increase in cytosolic calcium ion concentrations, and it's going to cascade here. This leads to activation of calcium calmodulin, as well as an activation of the myosin light chain kinase, MLCK. What does this eventually lead us to? Well, smooth muscle contractions, the phosphorylated myosin combining with, it's supposed to be actin, I'm sorry about the typo, actin filaments. Now, if you think about it, oxytocin plays its role in the myoepithelial cells and in its action on the smooth muscle cells. So this basically makes a lot of sense. Obviously, there's going to be, as a result of this calcium ion flux, and because of IP3 and DHE, you're going to also have some structural genes turned on. For example, with the cell gap junctions in the smooth muscles, at least that we know of in the uterus. So all of this is going to basically kick off a lot more structural contractivity that can occur in those smooth muscle cells and the myoepithelial cells. Okay. And obviously you see here, what is the mechanism that occurs? We've had oxytocin in the blood, and we've had the baby suckling. And basically, the oxytocin that's already there, it's going to make the uterus contract. But you've got these sensory impulses that are going to feed back from the nipples being stimulated by the baby suckling, and that is going to cause the milk letdown reflex. Okay? The milk letdown reflex, as you can see from this diagram, it's a little bit more detailed. The nerve cells in your nipples will signal the brain to release oxytocin. The oxytocin causes, and they say muscle, but it's really more myoepithelial. It's sort of like a smooth muscle. In the breast to contract, that's going to force the milk forward and basically out of the milk ducts. Okay? Now, let's take a talk for a second about control of release. Obviously, mechanical stimulation of the uterine cervix by the fetus near the end of the gestation is going to occur. Oxytocin release can be inhibited, though, by progesterone. Hence, at childbirth, usually what's happening is progesterone levels are going to decline. They have to decline, even though estrogen levels are continuing to stay up there and increase and stay at a present level. Now, stimulation can also be due to the neurotransmitters acetylcholine and dopamine. And also, as I mentioned before, when we talk about triggered for release by stimulation of the tactile receptors of the nipples of the lactating breasts by suckling. Now, let's go into a few other little details that might be very interesting. Now, in certain situations where there was a difficulty in the childbirth, now this is probably well before they really went wild with, and I say wild because it's much more common to be used as a procedure, is a C-section. But what doctors would sometimes do is to enhance the contractions of that uterine myometrium. They would give an injection of oxytocin. It was under the trade name of Pitocin, and that would enhance the contractility. It has also been found that oxytocin has been used as a nasal spray for the treatment of autism, autism spectrum, and some sexual function disorders. Now, if you have to think about it, the nasal spray is applied. Keep in mind that oxytocin, if you directly injected it, might not get really to the brain area that you want. Okay? Long trip through the circulation system. Also, it's unbound to any proteins and in the blood. And so it's, half-life is 1 to 5 minutes. That's not going to be lasting long. Rather, when you have this basically as a nasal spray, you're much closer to the brain, much easier for uptake, and thereby having an effect on the brain. There are several other stimuli that can inhibit release of oxytocin: severe pain, increased body temperature, and loud noise. It's interesting to note that there are no known diseases from oxytocin excess that have ever been identified. Normal oxytocin levels have been found to be normal in even cases of diabetes insipidus. In other words, even though you're still getting no or very, very little amounts of arginine vasopressin, you're still getting normal amounts of oxytocin. Okay, so when one pulls a blood and looks for the levels of oxytocin, compares it to arginine vasopressin, We've got nothing of AVP, but we've got still normal function of oxytocin. So that would rule out, for example, damage along the infundibulum. And we'll just continue. Here's a model, as you can see. Oxytocin, nasal spray. Now, when they start putting down real results and all that, I kind of get a little squeamish and going, well, maybe it's a little bit pseudo whatever, but it has been available. And so it's been touted as being a means to help with social fears, anxiety, stress, limiting some food cravings, perhaps enhancing sex life, orgasms, improve sleep, as well as dealing with some of the issues or symptoms of autism. Now, Asperger's was, as I said, the older name. It's now called autism spectrum disorder. Okay? So let's move from oxytocin to vasopressin. As I said to you, that goes by several other names. Arginine vasopressin, AVP, antidiuretic hormone, or ADH. Whichever way you do, you remember it as long as you understand what it is and what it does. What is its principal effect? That is to increase water reabsorption by enhancing the permeability of water in the kidney distal convoluted tubules and in the collecting ducts. If you remember the structure of the nephron, you start off at the glomeruli, you've got raw filtrate there from the blood, okay? Now, at that point, you make 180 liters a day. Obviously, you're not sitting there camped out in the bathroom all day. And yes, you can chuckle. I try to make this with respect, but at the same time, add a little bit of humor. Think about that. Normal people will basically, at the end, um, have diuresis of about 1.5 to 1.8 liters per day. So what's going on? Well, that raw filtrate is going to have lots more sodium, potassium ions. It's going to have glucose. It's going to have amino acids. It's going to have water, 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 water. So what happens is, in a survival sense, we have this mechanism to pull back water, and it is extremely important. Now, AVP also will increase vascular resistance. Basically, what it does is vasoconstriction. This, of course, would lead to an increase in blood pressure. Now, it's important during times of severe dehydration, severe blood loss, such as hemorrhagic shock, or systemic infection, such as sepsis, especially if the other vasoconstrictors fail to respond. So AVP is absolutely essential if you have someone who is just coming into the emergency room. They have been stabbed. They've lost 10, 20% of their blood. They've got AVP that's pumping away, and it's basically causing vasoconstriction to keep the blood pressure up. Okay? But we'll get more into that in a little bit. Now, it's interesting to note that the circulating concentrations of AVP range from 1.5 to 6 nanograms per liter. Remember, it, like the AVP, like oxytocin, circulates freely, unbound. Let's talk about the receptors. Now, there are 3 primary receptors that are going to be receptors for vasopressin. The cellular effects of AVP are mediated by binding to G protein coupled membrane receptors. Now, all of these receptors require a secondary messenger system for cellular response. So let's go over the receptor types. V1R. This is coupled to a G protein called GQ/11, specific only for AVP binding. These receptors are located in the liver, smooth muscle, brain, and adrenal glands. What binding to this and activating it will occur is it activates phospholipases C, D, and A. And this is thought to stimulate the hydrolysis of phosphatidylinositol. Okay, this is where you're going to get the vasopressor effects of AVP, and it's mediated, of course, through V1R. Okay, so think about this for a second. You have to have circulation occurring, and through adrenal glands and smooth muscle, liver, but especially the brain. So this is how we're going to have this to keep up the blood pressure if there is a loss in blood volume, or if we have a situation of actually blood pressure dropping due to some other problems. The second receptor type is V2R. This is coupled with a GS protein complex. This is expressed in the principal cells of the collecting ducts of the distal nephron. This is where you're going to see a lot of your water reabsorptive effects. So what is going to happen here is GS is involved with the binding that activates adenylate cyclase. Obviously, adenylate cyclase makes cyclic AMP. So you have this release of cyclic AMP, and this is going to lead to phosphorylation of aquaporin 2. To help you to understand this, and you can see this in your text, aquaporin AQP2, there's 4 of them. AQP1, 2, 3, 4. AQP2 is sort of held in reserve. And these receptors, once they are phosphorylated, will move in and insert into the luminal membrane. What I'm saying is they insert into the tubular luminal membrane side, tubular cells, excuse me. And what they're going to do is they're going to help pull in more water from that filtrate. Okay, and we'll go over that a little bit more in a few minutes. And then finally, V3R. This is coupled with GQ/11. It's expressed in the majority of the anterior pituitary corticotroph cells and in kidney, thymus, heart, lung, spleen, uterus, and breast. Now, binding stimulates the activity of phospholipase C, PLC. And so this is going to result in an increase in intracellular calcium. Okay? Now, if we move through here, you can see a little bit of this. In essence, what we're saying to you is that there are 3 types of receptors, 2 big ones that are different. Okay? When you talk about vasopressin, arginine vasopressin, if it goes to V1, you're going to start seeing this vasoconstriction that occurs in a lot of the vessels. This will, of course, increase arterial pressure. Okay. Now, V2, this is the one that plays a key role in the kidney. And this is where you're going to see renal fluid reabsorption. You're pulling more water out of that kidney filtrate and bringing it back into the body. And so this is going to assist in increasing the blood volume. Now, let's go back to that analogy. A gentleman or lady, whatever, coming in with a severe stab wound. They have come into the ER. They've lost 10, maybe 15, maybe 20% of the blood. They lost 20%. That's a serious situation. So what you're going to do is vasopressin is going to be released, but it's going to have a 1-2 punch. It's going to help increase arterial pressure, even if there is blood loss, because you're going to have vasoconstriction. It's going to also sequester more water to help, and this water is going to be put back into the blood volume to try to keep up the blood volume, even though some of the blood has been lost. All right. Now, how does all of this occur? Well, the fact is that we have both osmoreceptors and baroreceptors that are going to detect different categories of the volume and the pressure. So let's take osmoreceptors first. They detect the increases in osmotic pressure. Okay, remember, increases in osmotic pressure, you're going to have more dilute, okay, blood. And so you're going to have basically the release of antidiuretic hormone, or ADP. And first you're going to have the blood vessel having vasoconstriction. The baroreceptors, which are located, and by the way, osmoreceptors, if I didn't make it clear, those are located in the hypothalamus. But the baroreceptors, these detect for changes in blood pressure. So baroreceptors would be located in the aortic arch, in the carotid sinuses. They're going to detect if there's a decrease in blood pressure. Again, this is where you also will have AVP coming to the rescue because it's going to enhance reabsorption of water. So this 1-2 punch will lead to an increase in blood volume as well as an increase in blood pressure. So just let's go over a few moments the physiological effects in the big picture. Okay, what we're doing is doing water reabsorption and conserving of water. This is involved with the kidney. We're going to have a proximal tubule of the nephron responsible for reabsorption of 90% of the water from the kidney filtrate. That's a known. What I mean by that is it's accepted. You're going to have some pullback of the water, but that's not enough. The reabsorption of a further 10% is going to occur in the distal collecting ducts under the control of AVP. As we mentioned before, what's going to happen? AVP is going to bind to the V2R receptor. This is going to trigger cyclic AMP production, which is going to activate protein kinase C, which phosphorylates the water channel aquaporin, AQP2. These channels will insert into the luminal cell membrane. Okay, this is facing the filtrate. This is part of the tubules. Okay, the collecting duct and the distal part of the tubule. So what happens? It's supposed to be AQP2, sorry about that, increases the water absorption, pulls even more water. Now the water is going inside the cell. How does it get out? This is where you're always going to have, and they're what's referred to as constituent, meaning they're always there, are another set of aquaporins, aquaporin 3 and 4, AQP3, AQP4. They're all attached to the basolateral side of the cell membrane, so facing outward, okay? And they're going to release that water into the interstitial space, which happens to be occupied in part with capillaries. And that water is going to get transported into the capillaries and then back out of the kidney venous flow. And by the way, this is a relatively quick process. It can occur within a few minutes once you've started producing cyclic AMP. Okay. Now, there are a couple of factors to keep in mind, so I figured I'd go a little bit more and review this with you about aquaporin. Keep in mind that aquaporin is a channel, a cellular channel that allows water to come in. All right. So AQP1 is constitutively expressed in the apical and basolateral membranes of the tubule cells, proximal tubules, and the descending limb of Henle's loop. This is going to help control 90% of the water reabsorption. Now, AQP2, this is the biggie, this is what we want, is expressed only in the collecting ducts. AVP directly controls AQP2 and is inserted into the luminal membrane. So it's going to pull more water out of that filtrate. Okay. AQP3 and AQP4 constitutively means that they're always there. Okay. And they're going to be expressed into the basolateral membranes of the collecting duct. So basically, they're going to face the outward, away from the lumen where the filtrate is being processed. But what 3 and 4 are going to do is they're going to enhance water reabsorption following AQP2's insertion into the lumen membrane. So they assist in getting the water out of the cell so you don't have the water build up in the cell and then having cell lysis. Now, the filtration facts, you have to keep this in mind because this is where it's going to be important for your case studies, as well as just understanding basically how important AVP is. Normal kidney glomerular filtration is 180 liters a day. In other words, as the blood is passing through the kidneys, you're going to make basically this, what some of them have referred to, they call it a raw filtrate, right out of the glomerulus, 180 liters a day. But I don't urinate out 180 liters a day. Oh my goodness, that would be a serious medical problem. The normal urine output for you and I is 1.5 to 1.8 liters a day. Okay, fine. What if I didn't have arginine vasopressin at all? Then we have a problem. The urine output increases, and it's going to be at 18 liters a day. Now, it will be a dilute urine. Keep this in mind, okay? It is going to reduce its osmolarity because what you've got is basically a dilute urine, okay? So the antidiuretic mechanism will increase urine osmolarity to approximately 1,200 millimolars per liter and reduce urine flow to approximately 0.5 milliliters a minute. Now, if you get lost there with the numbers, think about it this way. What am I saying? The antidiuretic mechanism, okay, we're back. Just to help you, the antidiuretic mechanism is going to increase the urine osmolarity. So in other words, what I'm saying to you is you're going to have a decrease in water, an increase in solutes, okay? All sorts of other substances, including urea, okay? But at the same time, obviously, there's going to be the speed or the flow is going to decrease. And that's because instead of it passing through, you're going to have more and more of the components of the urine, particularly water, decreasing. So that's going to decrease the flow. I hope that helps. Now, here you see a nice diagram. I like this one because here's the big deal. If you have concentrated urine, how do you have that? It's because of vasopressin right here. Vasopressin will bind to the V2R receptor. We're going to kick off protein kinase. You're going to have this phosphorylation occurring. Of course, you've got buildup of cyclic AMP. Notice that you always will have the AQP3 and 4 out here. This is the basolateral, which faces the blood. Here's the concentrated urine. Now, what's going to happen in these little vesicles that contain these channels, these aquaporin channels, is they're going to get pushed up into this membrane here. This is the apical side, otherwise known as the luminal side, and you're going to pull out more and more water. As you pull out more water, the pressure of the flow is going to decrease. The concentration of solutes versus the solvent being water, is going to be altered. It's going to get more concentrated. Well, let's take a look at this from another perspective. I don't have vasopressin here. I don't have the V2P, which is the vasopressin type 2 receptor being bound to, so there's no phosphorylation. There's no trafficking of AQP2 into this side of the membrane. So what happens is you have a much more dilute urine passing through. To help you to think about this in another way, it's really important. The more water you lose, the more you're going to have a concentrated blood, and the more you're going to notice that the urine is going to be much more dilute. Okay? Concentrated urine, that's when you're going to start seeing it being more of yellowish. Dilute urine, more clear. Okay, I hope that helps. Here you have another situation where they go through the cells and they go through the receptors, and you got the GAS being activated, and of course cyclic AMP. And you go through this phosphorylation here, and you have the insertion of the AQP2 pumps channels. Okay. This is the final one here. I liked this one also because here's the idea. This is the tubular fluid, okay, the filtrate. Okay, and this is in either the late distal tubule or connecting duct cells. All right, so this would be what they refer to as the luminal or apical side. This would be the basolateral membrane side. There's a little peritubular fluid here, and that's going to get transported right into the peritubular capillaries right here. ADH comes in, activates the receptor, activates the G protein. We've got cyclic AMP, protein kinase A, phosphorylation here of these aquaporin 2s. They embed here, and now you start pumping even more water out of the tubular fluid as it's going in this direction. How's that? Keep in mind that this is supposed to have these tight junctions here, so fluid can't get between the cells. And what you're going to also have is you're going to have a lot more activity of the AQP3 and 4 aquaporin pumps, aquaporin channels, excuse me, and they're going to be moving that water out. Okay. Now, vasopressin, vasoconstrictive effects. So we've talked about the water reabsorption. Let's talk about the vasoconstrictor effects next. AVP binds to V1R. This is going to result in the vascular smooth muscle constricting. If you remember in arteries and veins, they have them, vascular smooth muscle bundles. It's much more profound in arteries, and thereby it's going to basically cause the arteries to constrict, and their lumen diameter is going to be reduced, and therefore the pressure is going to increase. So renal medullary blood flow is also under AVP control. Okay. Yes, we will have vasoconstriction at other places, but also one of them will be the medullary blood flow in the kidneys. Okay. AVP circulated unbound. We've talked about this before, and is distributed in a volume equal to the extracellular space. So what I'm saying to you is, in this case, in the extracellular space, it's very easy for AVP to move from blood into extracellular space and thereby act on the cells. It's not like it needs a pump. It's not because it's a huge molecule. It has a low molecular weight. Also, AVP is permeable to peripheral and glomerular capillaries and is excreted in the urine. So one test that can occur is looking for AVP in the urine. And now, mind you, again, antidiuretic hormone, ADH, is equal to arginine vasopressins. Same thing, okay? What you have, we've already talked about in part, is the antidiuresis. So it is against excessive urine production, prevents this by basically enhancing water retention. So you don't have a dilute urine, you have a concentrated urine. The vasopressin will cause vasoconstriction, which this is why you had two or almost like ADH, AVP, it's the same thing. The names were different, but they really were doing some of the same things, same hormone, okay? Both of these are going to lead to an increase in blood pressure. Now, later on in the course, we're going to talk a little bit about angiotensin and angiotensinogen and sort of the RAAS system. AVP can be influenced by angiotensin 2. And hyperosmolarity is another one. Decreased atrial receptor firing. Now, when you say decreased atrial receptor firing, well, in the atrium, you have a hormone, which we'll discuss probably later on at the end of the course, natriuretic, atrial natriuretic factor, which actually does the opposite. It enhances water excretion and sodium excretion. Okay. But all of these plus sympathetic stimulation will act on the hypothalamus, which will cause the posterior pituitary to release vasopressin. As you can see here, it's a pretty straightforward. V1 leads to constriction of the blood vessels. The V2 receptor is involved with the kidneys and fluid reabsorption. By vasoconstriction, you increase systemic vascular resistance. By enhancing fluid reabsorption, you increase blood volume, and therefore you end up with increased arterial pressure. Now, how do we control the release? Well, we've already started mentioning some of this. As I mentioned to you before also, AVP is released into the circulation. It is unbound. All you have to have, though, is either an increase in plasma osmolarity, and that seems to have the greater impact, or the decrease in blood volume. Plasma osmolarity here, think about it this way. Solution is made up of both solute and solvent, right? Solvent is the water. Solute would be all the other components that make up blood. Okay. So if I have an increase in the plasma osmolarity, that's meaning that I've lost water. And I have to bring back or elevate the water, because otherwise I'm going to have a decrease in blood pressure. Now, it could be also in combination, I have a decrease in blood volume. I got stabbed. Something happened. I've lost a lot of blood. So these are some of the triggers. Now, changes in osmotic pressure are detected by the osmoreceptors. They're located in the hypothalamus and in the lamina terminalis. Dehydration produces loss of intracellular water from the osmoreceptors, which results in cell shrinkage. So in other words, these cells, if there's a great osmolarity, they will lose some of their own water as it will be pulled out. It's going to go in a passive transfer, okay, osmosis. This is going to stimulate the magnocellular neurons to release AVP. And now this, mind you, is what is so cool. Even before we sense thirst, even before we have that sensation of thirst, this is already taking off and occurring. Now, excessive water fluid intake can result in cell swelling and stretching and hyperpolarization of the magnocellular neurons, resulting in a decrease in AVP release. Okay, rarely does this really happen, but I'm going to tell you one example. Some years back, a couple of shock jocks on the radio decided to have a contest for someone which would have gotten them a Wii the computer game consoles. So they basically had it hold your Wii for Wii. And basically they told them drink lots of water and so on and so forth. And the one that can hold out the most gets the Wii PlayStation, whatever it was called. They actually had a woman doing this. And she called up and said, I'm in bad shape. Da, 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 da. And they thought, oh, she's full of baloney. And they called a nurse and they said, she's got to get into the doctor quick. She's in a serious situation. She has hypervolemia. Unfortunately, the woman didn't get there in time and she died. Shock jocks were fired. Station was sued. Of course, the makers of Wii were very embarrassed and had to, we're sorry about this. But this can happen. Some people can have excessive fluid intake. This can also happen with excessive fluid intake in IVs. And so one has to be careful of the delivery and the type of material you're putting into the vein. Now, also, AVP secretion is also stimulated, as I mentioned to you, and I will give you some numbers here, by a decrease in blood pressure of greater than 10%. Okay? Now, I said if you had a loss of, the body usually has about 5 liters of blood. So if you have 10% loss of the blood, we're looking at half a liter. We're looking at 20%, that's a full liter. You're in a serious situation. Now, what happens there is you're going to have decreases in blood pressure or blood volume. These are going to be detected by the pressure-sensitive receptors in the cardiac atria, the aorta, and the cardiac sinus. Now, also, these factors that reduce cardiac output, in other words, a decrease in blood volume, such as orthostatic hypotension or positive pressure breathing, all of these factors, reduction in cardiac output, orthostatic hypotension, positive pressure breathing, are stimuli for AVP release. Now, where else can you alter vasopressin release? You can have the release of AVP that can be modulated by estrogen and progesterone. Some women report this, and when they have a decrease of estrogen, progesterone, around the time of their period, they will report that they suddenly now will go and have a greater amount of diuresis, going to the bathroom. You will also see modulations occurring by opiates, by nicotine, by alcoholic beverages, and by atrial natriuretic factor, which I've mentioned a little bit about before. Let me just give you the best sort of common example. You go with your friends and you're having a beer at the bar. And after a bit, you have to go, oh, well, I had the beer, now I have to go to the bathroom, if you'll excuse me, and you go off to the restroom. Okay, folks, it's not the fluid in the beer that made you go to the bathroom. It's the alcohol in the beer that turned off AVP release. It basically shuts it off for a short period of time as long as alcohol is present, ethanol. And now what you're doing is producing a much more dilute urine, and that causes you to want to go to the bathroom. Okay? Now, what about vasopressin disorders? There are some points you need to be aware of. First off, deficiency of AVP results in production of large volumes of dilute urine. Excessive AVP release results in small volumes of very concentrated urine and hemodilution leading to hyponatremia. Okay? Basically, what's going to happen is you're going to hold on to a lot more water, and in the blood, you're going to have a decrease in the concentration of sodium ions compared to the amount of water. As you've been holding back on your water, you're going to give off a very concentrated urine, easily seen because it's going to be much, much more yellow in color. But at the same time, you haven't altered the amount of sodium. You've increased the amount of water that's there, and therefore, comparing the water and the sodium concentrations, with the greater amount of water, you're going to have apparently, it's going to look as if you're having a decrease in the concentration of sodium ions in your blood, and that's going to be having a very terrible effect. Now, there is a condition called diabetes insipidus. Excuse me, it's supposed to be INSIPIDUS. I'm sorry, I did my spell check. I guess I missed that one. Anyways, diabetes insipidus is a condition where you produce abnormally large volumes of dilute urine. Now, there are several different ways that this can occur. I want you to be aware of diabetes insipidus because it can occur and is not unusual. It differs from diabetes mellitus in the sense that, when people hear diabetes, they always think of, I need a shot of insulin. Well, that's diabetes mellitus. That's dealing with a completely different hormone, insulin. Diabetes insipidus deals with AVP. Now, there are three ways or three types of causes for diabetes insipidus. First, neurogenic. That can be either the central nervous system or the hypothalamic. Most common cause of decrease in the release of AVP. Diseases can affect the hypothalamic pituitary axis. And this can lead to the neurogenic type. It can also be caused by traumatic, inflammatory, or infectious causes that are around the HPA. Traumatic, example, auto accident. You hit your head on the steering wheel or something else like that. Inflammatory, there is some sort of inflammation that has occurred, particularly around the infundibulum, or it can be in the hypothalamus, or to a lesser degree in the posterior pituitary. This will reduce the amount of AVP released. Finally, infections, various brain infections, various central nervous system infections can lead to the neurogenic diabetes insipidus. Now, renal decreased responsiveness to AVP. This is called nephrogenic. Nephro meaning for the kidney. This results from a renal insensitivity to AVP. So there's a difference here. You could do a blood test and you will see normal levels of arginine vasopressin. The kidneys aren't responding. This is another one of these situations where they send out the signal, but there's nobody listening. Now, this can be inherited or acquired. There is a type of X-linked recessive mutation to AVP for the V2P receptor gene. 90% of all the cases are males. Small number of cases of inherited nephrogenic DI are caused by mutations in the AQP2 channel gene. Okay? There is also the possibility of excessive water that does not involve alterations in ADH release at all. Here you see an example of what I was mentioning before, the hyponatremia. Now, if you notice it as R/O, this stands for rules out. You have to rule out nephrotic syndrome if you have hypovolemic volume status. When you say volume status, we're talking about normally the amount of blood or fluid in the blood status, okay? Euvolemic, that's normal levels. Hypervolemic, that's something where you have an increased amount of either blood volume, or usually it's more either because of the water or whole blood as it is. It also could be caused by excessive amounts of the proteins that are in the blood too. But let's take this hypovolemic. You've lost fluid. A lot of times the fluid loss could be caused by vomiting and diarrhea. Okay, so you've lost a lot of fluid, and the fluid compared to the sodium levels, its loss is going to show up in a hypovolemic situation. But you got to rule out nephrotic syndrome. Nephrotic syndrome are some of the disorders that occur around the kidney. Euvolumetic means that you have normal volume of the blood. How am I still getting hyponatremia? SIADH, which we'll talk about in a minute. But in the meantime, you have to rule out Addison's disease, diuretics, hypothyroidism, paraneoplastic syndrome. Paraneoplastic has been bounced around. It's basically syndrome indicating that there is some active cancer that exists in the body. Okay? So hypervolemic, you have a much greater amount of volume. It can happen with renal failure because now what you're doing is not filtering. Okay? Chronic heart failure or cirrhosis. Okay? Cirrhosis, what happens there is that you are not having the proper number of proteins, including some of the common proteins, albumin, etc. And so what's being taken up is a much greater amount of fluid. And again, that disturbs the concentration of sodium. Okay? Now, vasopressin disorders. Now, I want to bring up these before we get into SIADH. There are other causes of altered AVP levels. Acquired nephrogenic DI can occur due to lithium treatment. Individuals who are on lithium for extended periods of time, doctors have to watch them very carefully so that it does not interfere or damage the kidneys. Hypokalemia, which means that you have a low amount of potassium present in the blood. Post-obstructive polyuria. Okay. And usually that's something where you're making a lot of urine, but there are some obstacles or some structures that are blocking some of its release, etc. Finally, let's get into SIADH. Stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. If you recall in the first week, I mentioned to you the situation of, hey, if you have cells that are endocrine and they go cancerous, boom, you're going to start having the massive increases in whatever hormone that particular cell was originally making, but now it's going to be desynchronized, not necessarily under the control of either positive or negative feedback. Sometimes you'll have SIADH and you're having tremendous amounts of AVP. So what's that going to consist of? Hyponatremia. Again, you're holding back in a lot of water. It's going to dilute down the concentration of sodium, and so it's going to be hyponatremic. Inappropriately elevated urine osmolarity. Now, what that means, of course, is, hey, the concentration of solutes is strangely elevated. Now, why do I say strangely? How could you tell? Because there's a bunch of other factors that are there. You're producing normal quantities of urine and of various other factors. All other factors seem to be normal. But still, you're getting this massive swing of AVP. You will have excessive urine sodium. You will have decreased serum osmolality in a U volumetric, in other words, normal circulatory or blood fluid volume within the body of the patient. Now, what can cause this? One, brain injury or a tumor production of AVP. It is one of the cardinal signals for lung cancer that the person has SIADH. In other words, a lot of the lung cancers will start kicking out AVP uncontrollably. So malignancies of the lung, brain, other organs have been found to produce excessive AVP. There are, of course, other causes of elevated AVP, including medications. For example, serotonin reuptake inhibitors, opiates, and monoamine oxidase inhibitors. These medications can cause abnormal elevations of AVP. You can also have central nervous system disorders such as stroke, traumatic injury, and infections. Finally, pulmonary disease and surgery, especially brain surgery, can lead to elevations in AVP. As you can see this here, you have this entire chart. I tried to get it a little bit sharper, and I apologize if it doesn't come out as well, but this gives you some idea about, the drugs, the malignancy of this causing SIADH. Also, you'll notice something else. If you look at the disorder, SIADH, serum sodium is down. The serum osmolarity is down. The urine osmolarity is increased. Why? Because we're holding on to the water. So the osmolarity, in which the amount of solutes present in that urine, is going to increase because a lot of the water that we normally had in the urine is going to stay in the body. And that's going to reduce the concentrations of sodium and just the overall osmolality of the serum. With dehydration, it's a little bit different. What you're going to have in dehydration is increases in serum sodium, serum osmolarity, and urine osmolarity. Dehydration, you're always going to see, for the most part, a much more concentrated urine. Okay. Diabetes insipidus, you're going to see increases in serum sodium, serum osmolarity. But the interesting thing is that the urine osmolarity will decrease. Okay. Now, that pretty much brings us to the conclusion here. Now, I just made a correction here. Right now, for this coming week, we're going to meet at 5 o'clock on Thursday for Zoom. Okay. You want to have your case studies done beforehand. Have them submitted. Okay. But I'd have a copy with you because we'll probably go over some things to increase and review and make any corrections for each and every one of you. Okay. As always, the case studies that are handed in, documents will be graded on completeness, accuracy, and correctness. We're going to review them on Thursday. What I would say to you is this: I do give some consideration. It's like, well, okay. And we had one student that asked a very good question last week. It was a noggin noodle. And what I mean by that, it was, okay, how come it's pituitary as opposed to hypothalamus? Those are great questions. Ask them. Now, also, I want you to review again the vital signs data on the blackboard, along with your book appendix. Now, obviously, we're not going to ask you to memorize all the numbers. What we are going to have you do is take a peek at some of the ones for this week, and that would be, urinalysis, and that would be blood pressure, and that would be amounts of the hormones present in the blood, the osmolality of the serum, things like that, sodium levels, etc. Because this may help you in determination of the case study diagnosis.